There's no question that ADCs are causing a real ripple of excitement and interest in the lung cancer space, and the evidence that we've seen so far in terms of benefit to patients clearly supports that excitement, at least for some of the drugs. The way in which an ADC works is dependent upon recognition of some molecule on the surface of the tumor cell, leading to internalization of the drug and release of the chemotherapeutic agent. So the obvious question is, does the efficacy of this drug depend in some way on the presence or absence of that protein? Ergo, we are talking about biomarkers in this space. And so far, it looks like some of the drugs do have a dependency one way or another on a biomarker. Interestingly, with trastuzumab deruxtecan, the HER2 agent, the best results that we see are with patients who actually have HER2 mutation. And those outcomes are independent of the presence of the protein on the surface of the tumor cells, which is curious, but it is what it is. And those good results are probably, at least in part, the result of some kind of inhibition of the oncogenic signaling, as well as release of the chemotherapy inside the tumor cells. So setting that slightly different scenario aside, all of the other drugs, well, some of the other drugs have this dependency on a immunohistochemical biomarker. So some of the drugs in the HER2 space, in HER3 not so. In MET, there is good evidence that the drugs need a positive biomarker to indicate likelihood of response. Similarly with some of the drugs targeting CEACAM. The other side of the coin is with HER3 and with Trop2, probably for different reasons. The biomarker does not seem to be an issue, and so it's not really being pursued. I think we've got a lot more to learn in this space. There are lots of different confounding factors which might explain some of the changes or some of the data that we've seen. I think that possibly in this particular therapeutic space, when we think about second line, there may not be so much interest in selecting patients. There might be more of an interest in simply treating everyone and crossing your fingers as to the outcome. In second and greater line, it's never going to be the magnificent response rates that we see from some of the first line therapies, but still more to learn. But I think undoubtedly for some of the drugs, we are going to be looking at an immunohistochemistry, or in the HER2 case, a mutation biomarker, which will be required for use of those drugs.